So I'm going to talk about nailing in an established infected non-union. Nailing infected non-unions are not a new problem. We have been facing them ever since we started orthopedics. I will cover this topic under these 4 or 5 headings: brief introduction, principles of treatment, options, and then the role of nailing and our experience and what we can expect the future of this problem, how we can manage it in future. Friends, any non-union can have one or more than one causes. So there are a variety of things which can lead to non-union. Whenever we see a non-union, we must always look for cause, maybe more than one. Today we are going to talk about infection, which can be pyogenic, tubercular, or fungal. Infected non-union or non-unions have been classified in many ways, but we classify them as a practical treating approach. Either it is aseptic or infected, and in both cases it is either with a gap, manageable gap, or extra gap more than 1 inch or more than 3 centimeters, where the treatment modalities would differ. So that is our practical way of classifying. When it is an infected non-union, the union and infection, they propagate each other. If there is infection, it will not let it unite. And if the fracture does not unite, it will not let the infection heal. So it's quite a vicious circle, and we need to break that, and it's a big challenge for the orthopedic surgeons. What are the principles of treatment for infected non-union? Because infected non-union have another problems apart from infection and non-union, and these are soft tissue problems, poor general condition, and comorbidities. We have to look after them as well, along with infection and non-union. So the principles of treatment for infected non-union are as follows. Soft tissue. We must get a good soft tissue, and if it needs cover, we must get a plastic surgeon to cover a soft tissue. We must get control of infection with adequate debridement, antibiotic therapy, which is mainstay of antibiotic therapy is local antibiotic delivery system today, and systemic as well for some time. Any comorbidities need treatment. Stabilization of bone. There are varieties of ways of stabilization of bone, and presently interlocking nail is probably the best. And then biological supplementation of fracture union. All these principles have remained same for last 50 years or so. But methods have changed as the technology and our understanding of various technological advancements have increased. So basically, we control infection, improve mechanics, and supplement biology. What are the treatment options for soft tissue cover? Split thickness skin graft if satisfactory, or local flaps are better than the distant flaps. And if free tissue transfer at all is required, fasciocutaneous is better. As far as infection is concerned, aggressive debridement. Aggressive debrima is the mainstay, and there are ways to assess how to know whether the debridement is adequate or no, and then we control the infection, and for that we have to achieve increased local concentration of antibiotics to decrease the systemic toxicity, and for this we need to have local antibiotic delivery system. And these delivery agents of antibiotic at local site of infection have changed over the years. Earlier it was antibiotic cement beads. Then we also have antiseptic coated nails and antibiotic cement nails, and interlocking intramedullary nails as antibiotic dispensers have also been used. And masquerade technique is another one where we use a membrane. Now, with local antibiotic cement beads, there is need for reoperation, and they decrease the osteoblastic activity. And this, to overcome this, we have now available bioabsorbable, osteoconductive, and even osteoinductive materials for local antibiotic delivery. So a second operation is not needed, and this is almost a reality today. It is also available to us in India now, and there are varieties of things, calcium sulfate pellets with or without BMP and collagen sponge, calcium phosphate cement with chitosan, antibiotic impregnated bone graft, and the studies are on to control the elution of antibiotics even from bone graft. In a controlled manner, antibiotic can be eluded at local delivery, and platelet-rich plasma also has been used. Now, very recently, just last month, there have been 2 publications on bone grafts mixed with granulocyte precursor cells used as antimicrobial agent. and bioactive, osteoconductive, antimicrobial, biodegradable 3D printed platforms which have been used as for gap situations as antibiotic dispensers or antimicrobial drug dispensers. So what are the various, now coming to the enhancing the bone graft, the bone union process, what are the various bone graft options? Of course, autologous cancellous bone graft is gold standard, but there are other now with reduced morbidity, reamed irrigation aspiration bone graft which is available, which reduces morbidity, and there are other bone substitutes, allograft with or without bone morphogenic proteins and growth factors, added to growth factors, and then there are strut grafts for gap situations. Now, the treatment methods during last 4 or 5 decades have changed, though the principles of treatment have remained same: control infection, improve mechanics, and supplement the biological process. They are the principles, age-old principles, and they will remain the same. The methods will keep on improving to reduce the morbidity and to improve the efficiency. Usually this has been a staged procedure. Era 1, about 50 years back, it was cast and traction to control infection, parenteral antibiotics, and then supplementation with stabilization with cast. And then there came an era of rigid plating with bone grafting. Then came an era of external fixation with antibiotic cement beads, and then Ilizorov techniques or various external fixation techniques. And the latest is antibiotic cement nails with or without antibiotic cement beads, and now the biodegradable antibiotic dispenser, and that makes the treatment as one-stage treatment with reduced morbidity, and this is what is the future, and this is almost the present at this time. Mostly, at most places, the present practice is still two-stage procedure. The first stage is control of infection by antibiotic nail or antibiotic spacer or beads, and the second stage is we remove these beads and antibiotic nail and then ream again and stabilize with interlocking nail. And there are about 20 studies with about 90%, 95% success rate. Whenever we use external fixation, the complication is slightly higher. The Ilizorov techniques, there are about 30 studies in literature, but the complication rate is significantly high as compared to nailing. Now, nailing in infected non-unions, as I said, there are about 20 studies, but this was one of the first studies where they compared cast and plating and nailing, and they found nailing to be the best as compared. This is done about 25 years back. So ever since the nailing has been used, it has improved the results of any fracture, either fresh or infected or complicated fractures. Now these are the latest studies. This is the longest 43 long bone infected non-unions with antibiotic cement coated rods. And they found single stage success in 60% of cases, and 40% patients needed second operation, and then they achieved almost 100% result. And there is another study about 40 non-union. These are the two latest studies. Now this is a comparative study where they used X-fix and nailing or X-fix only, and they found X-fix replaced by nailing, initial period of X-fix, after which is replaced by nailing, is always better. Now, we have conducted various studies on non-unions and infected non-unions. I won't go into the details of data, but I will share some cases quickly with you. This is a case came across with this X-ray 25 years back to us. And these were his, 60 years male, wasted things. We asked for his old X-ray. I will quickly go through the old X-ray that patient was carrying. This is how he started in 1980. And then for 3 years, multiple operations, curettage, and finally landed up with us in this shape. And when we investigated him, there was sinuses, draining sinuses, serious discharge. He proved to be tuberculosis. So we started anti-tubercular treatment. I will quickly go through cases. External fixation, this was 25 years back. External fixation, anti-tubercular treatment, and then nailing. Another case, this is about 20 years back. By this time, we had converted to antibiotic cement nails. Infected non-union came to us in this position. Originally, plating was done, then external fixator. He came to us here, where we first built up the general condition, very poor general condition, then antibiotic cement rod and beads, and then removed the beads after 8 weeks and replaced with interlock nail and graft and went to union. From here, we could achieve this with this method. Another case came like this. I will quickly go through the case. This from, again, antibiotic cement rods and beads, and then he was also positive for tuberculosis because he was not healing on one side. And we started anti-tuberculosis treatment also. His knee was stiff when he came to us, then finally he healed. And this was the just last case we are going through.
Dr.
And from here
Aggarwal,
to here.
can you conclude?
Yes, this is another case which healed in single stage. There was a bone soft tissue cover needed, as you can see, a lot of local flap. Soft tissue cover was needed and he healed in one stage. The future, friends, is for bioabsorbable osteoconductive biomaterials for local antibiotic delivery system, intramedullary interlocking nails, controlled elution of antibiotics, use of BMP, and single stage treatment is very much possible. So the message is adequate soft tissue cover, local antibiotic delivery system. In our country, never forget tuberculosis if it's not healing with standard antibiotics, interlocking nail for stability, supplement osteogenic activity, and minimize morbidity. Try single stage treatment, which is very much possible today for these infected non-unions. Thank you very much.